I'm
This
Dr. Radhika.
conference will now be recorded.
Sorry about that. Okay, yeah,
Hello,
start.
I'm Dr. Radhika. I'm one of the doctors in the fertility clinic. May I confirm your name and age?
Yeah, I'm James. I'm 34.
How would you like me to address you?
You can call me James, it's fine.
All right, James, nice to meet you. So, Mr. James,
Like,
I have gathered from the notes that you've had some tests performed as part of your fertility workup, and you're here to discuss about that. Is that right?
yes, that's right.
All right. So, Mr. James, I'll be addressing all your concerns and going through your reports. But prior to doing that, is it okay if I ask you a few routine questions to understand your condition better?
Yeah, that's fine. You can go ahead.
All right, thank you so much for that. So, Mr. James, can you tell me how are you doing and what are your concerns so far?
Well, doctor, actually, I've been quite distressed for the past 3 years that we've been trying to, get pregnant, myself and my wife. And I don't know exactly what could have been wrong. So we've been visiting the GP. He's done some tests for her as well as me. She mentioned to me that he's told her that everything is normal with her. But in my case, I mean, I'm just running about. I'm wondering what is wrong.
All right, Mr. James. Mr. James, so you've been trying to have a baby since last 3 years. Can you tell me if you have any children, any by any previous relationship?
No,
All right. And do you have any headaches or any problems with the vision?
no.
Have you noticed any change in your shaving frequency?
No,
All right. Mr. James, in the childhood, did you have any infection like swelling behind the ears, like mumps, etc.?
no,
Hello?
no.
All right.
Yeah.
And have you noticed a change in your weight, a sudden rise or fall in weight?
No, I'm very particular about my weight. I'm a gym enthusiast.
Okay. And have you taken any medication to gain strength, like steroids?
Mm, no, I'd have to say no.
All right. Okay. And apart from that, do you have any? Some of my questions might sound personal and intrusive, but they're necessary for me to understand your condition better. Shall I proceed?
Yes, definitely.
All right. Have you ever been treated for any sexually shared infections in the past?
No,
All right. And do you have any problems with erection or ejaculation?
no, not at all.
All right. Do you have any cloudy urine at times?
No,
All right. Okay. And do you have any genetic conditions running in the family like cystic fibrosis?
no,
All right. Okay. And are you in the habit of wearing tight underwear or working in hot conditions?
not at all.
All right, okay. And can you tell me if you have any problem in the smell like do you feel like you smell less than usual?
No, I don't think so.
All right. Have you received any chemo or radiation therapy in the past?
No, doctor.
Okay. Any other medical condition for which you see your GP?
No,
All right. Any surgeries in the past?
no,
Okay. And do you smoke or drink alcohol?
no,
Pardon me asking, any recreational drug use?
no,
Are you allergic to anything?
no. I don't know.
All right. And how is the support at home?
I'm okay to do. I mean, I'm a professional
Mhm.
model and all of that, so it really, depends.
All right. Okay. And have you felt low or depressed in the last couple of months?
No,
So thank you for
this has
sharing all this.
been a stressful journey, but in general, no.
All right, Mr. James, I can understand infertility and going for trying to have a baby for so long can take a toll on any couple. If you would
Mhm.
like, we can schedule an appointment for you with the counselor for you and your partner.
Okay, okay,
All
sure.
right. So thank you for sharing this information with me, Mr. James. Would you like to add anything else?
No, nothing.
Okay. Another thing I wanted to ask you, Mr. James, was this the first time you have given your semen sample for
No,
testing?
actually, I have
Mm-hmm.
repeated this because the GP wasn't sure about. He said that they needed to repeat and see if the first one was wrong or whatever.
All right. And were you properly instructed before giving the sample?
Oh, yes, I have. It stayed for 3 days before collection and it was immediately done.
All right, okay. And apart from that, how much time was the delay in reaching the OPD once you gave the
No, like
sample?
I said, it was done
All
for the
right.
testing.
Okay.
Yes.
All right, Mr. James. So, Mr. James, I have your reports with me and I have confirmed your name and NHS number on this report. And before I discuss this report with you, would you like to have, it's slightly upsetting. So, shall I
What is it,
discuss it
doctor?
with
Of course, you
you?
can
Yeah.
tell me. Please go ahead.
All right. So, Mr. James, I'm really sorry to tell you that the semen test that was performed for you showed that there's a very less amount of sperms present in the in your sample.
Okay, but why is this happening again and again? I mean, there's nothing wrong with me in general. I believe everything is fine.
Absolutely, I understand that, Mr. James. We have also performed a hormone test for you as well, and that is also suggesting that the hormone which is released from the brain, which we call as FSH, that is also reduced.
Okay,
Okay.
but why? I mean, what could be the
There could
reason?
be absolutely, I understand that, Mr. James, and there could be number of reasons for this. But we might have to do some further tests to evaluate this. And I would also be telling you that from now on, your care will be by a team of doctors, including my consultant, um, the andrologist, the urogynecologist as well, the counselor. All of us will be taking care of you as a team. I would also like to advise you some lifestyle changes as well. Okay, like daily
Okay.
exercise and just reducing some stress. That will also help improve the sperm count. Okay,
Mm-hmm. Mm-hmm.
all
Okay,
right.
okay.
And sometimes what happens that sometimes the sperms are being produced, but they're not able to come out. We call that as an obstruction. Okay, as I can see that your testosterone hormone is coming out to be normal. So for that, we can do a special scan, which we call as an ultrasound scan, just to see your male organ, that is testes, to see if any sperms are being produced and being stored there or not. All right.
Okay, all right. What are my options, doctor? Will I ever be able to father a child?
Absolutely, I understand, Mr. James. So we do have options, like I mentioned, that we can do a special scan. And once we do that scan, if we see some sperms present, we can insert a small needle and extract some of those sperm, and we can fuse them with your your partner's eggs, and you can definitely have a baby by the assisted reproductive techniques. Or you can choose to go for adoption and adoption as well, or a donor sperm, if at all we do not find any sperms in your testes. All right.
Mm-hmm. Mm-hmm. Mm-hmm.
Okay. I would be also setting up an appointment for you with the fertility specialist. Okay. And they
Mm-hmm.
will be discussing regarding more about this. Okay. Do you have any other concerns for me?
I was just wondering, actually, Doctor, now that you had asked me, initially, I have been taking some sort of supplemental steroids. I'm really afraid now. Could this be because of that?
Mm-hmm. So you taking steroids?
Yeah, I am on, but
Mm-hmm.
I was instructed because it's not legal in every state that, I sort of didn't tell you that before.
Mm-hmm. All right, so Mr. James, that is a very valuable information that you've informed. And steroids can definitely affect the way the hormones interact with your organs, and it worsens the sperm production. All right, so are you still taking those steroids?
Yes, I am.
All right, so we will be liaising with your sports doctor so that we can gradually reduce the dosage and finally stop them. We cannot stop them abruptly because that can lead to problems. And once
Mhm,
we stop them, it takes about 4 to 12 months for your sperm
mhm,
count to come back to normal. All right?
mhm, 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 mhm.
Okay.
Okay, okay. So, yeah, so if this is the issue, then probably, I'll be able to have kids of my own then.
Absolutely, Mr. James. So once you stop this steroid injections, then after that
Yeah.
we will be following you up. We'll be checking your sperm tests again. All right,
Okay.
and definitely there is a chance that your sperm count will come back to normal. And I will be giving you some information leaflet and some support
Hmm.
groups. All right,
Hmm. Okay.
and set up another appointment.
Okay. All right. Yes. Thank you, Radhika.
Thank you, ma'am.
Right. We'll come to the feedback. But before that, our other volunteer, Dr. Aisha.
Yes, ma'am.
Okay. Again, I'll give you 1 minute.
Okay.
Okay. This is your station. All right.
Okay, ma'am.
Mhm. Yes. When you're done, we'll go to the next page.
Okay, ma'am. Yes, ma'am. Next slide, please.
Sure.
Okay, ma'am. Can you go to the first slide, ma'am? Okay. I'll start, ma'am. Hello, I'm Dr. Aisha Sadika, one of the doctors here. Can you please confirm your name and age for me? Hello.
Hello. Yeah, you can start now.
Yes. Okay, ma'am. Hello, I'm Dr. Aisha Sadika, one of the doctors here. Can you please confirm your name and age for me?
Yes, I'm James. I'm 34.
Nice to meet you, Mr. James. I see from the notes you're here in view of the reports, the investigations which were done previously. Is it fine that before I go ahead with the investigations, I ask you a few quick questions to know you in a better way?
Yeah, that's sure. Fine.
Yeah. All right, Mr. James. To begin with, in view of your previous visits, can you tell me more about it?
Well, we've been trying to get pregnant for past 3 years. It was
Mm-hmm.
honestly a frustrating wait, but we went to the GP to get everything checked out.
Mm-hmm.
My wife informs me that she's been told everything is good with her,
Okay.
but the GP somehow mentioned that I need to come and see you with my reports to understand better.
Mhm. I see that, Mr. James. And and has this been the first time this investigation was carried out?
Yes, it is.
All right, I see that. And Mr. James, have you fathered a child before?
No,
And did you ever have any complaints of headache or, visual disturbances?
no, not at all.
Any altered sensation of smell?
No.
And have you been taking any sort of medications in the form of steroids?
I used to. That
Mm-hmm.
was about 2 years ago.
Uh-huh.
When I had read up about the harmful effects of steroids on me in general, and I stopped it
Mm-hmm.
at that time.
And how exactly did you stop it? Like, were you in liaison with a doctor, or you stopped it all on yourself?
I stopped it by myself, just like I had started it. I had taken it
Mm-hmm.
only for a few months, yes,
Mm-hmm. I see. Few months would be around how many? Do you remember?
around 5, 6 months.
All right. Okay, I see that. And apart from that, some personal questions. How has your sexual life been so far?
There's no issues there at all. We are quite active, around 2 to 3 times per week, say.
Mm-hmm. I see that. And did you ever experience any cloudy urine?
No,
And any past history of chest infections or infections like mumps,
no,
and
not at
any
all.
history and any medical history of having diabetes or hypertension.
No,
All right. And in the past, did you ever have a surgery done on your genitals or any trauma to that area?
no.
I see that. And any social habits like alcohol or smoking?
No, not as such.
Pardon me asking, recreational drugs?
No,
And how do you work? What do you work, Mr. James?
I am a software engineer.
I see that. And are you allergic to any medications?
No,
And do you know your height to weight ratio?
it's 26.
All right, I see that. All right, Mr. James. Coming to your report, as we were about to discuss,
Mm-hmm.
I've confirmed the name and NHS number on this particular report, and I would want to tell you that I have some concerning news for you, Mr. James.
What is it, doctor? Go ahead.
Yes, Mr. James, I would also want to ask you, like, before you gave this sample, were you told about how exactly you have to give this sample, like the days of
Yes, yes.
abstinence?
Yeah, I've abstained for 3 days and I came to,
Hello?
yeah, I abstained for 3 days and I collected it in the lab.
All right, I see that. So the report does say that it's not a normal report. The sperm count, which has to be within the normal limits, is quite less than that, and it is a bit concerning to us. Are you with me,
Okay.
Mr.
Yeah, yeah, I am. Please tell
Yeah.
me.
So what we can really do is sometimes there can be some error happening. So it's always advised that we repeat this investigations as soon as we can. All right, Mr. James.
Mm. Okay. But
Yeah.
doctor, what could be the reasons for this thing?
Yeah, yes, Mr. James. One of the reasons why this might be happening is probably because of the steroid which you might have had taken. That can be one possible reason. Apart from that, to actually get to know why this has been happening, we might have to run a few more investigations, few more hormonal tests which we need to do, and to get to know the reason of this. Are you with
Oh,
me, Mr. James?
okay. Yes, I
Yes.
am. Yes,
Yes,
please.
so it mostly it appears to be because of the steroids which you are taking. So what we can do at this point in time, I will be liaising this with my specialized team of doctor, which would include my consultant, the fertility specialist doctor, the andrologist, the one who's involved in male sexual life, who deals with it, and also the sports doctor whom we can talk to and get to know why this has been happening. Alongside this, we can as well get these investigations done and probably fix another appointment in a few days time.
Yes, sure. But what if that report turns out to be the same?
Yes, Mr. James, I understand your concern. If that report comes out to be the same, and if you really get to know why this has been happening, regarding to the fertility aspect in itself, we have a few options. One of the options being that we can go ahead with this artificial. We have an artificial reproductive technique which we call the in vitro fertilization. Have you heard about this, Mr. James?
Not really.
All right, I'll just take you through it. In which what we can do is, we have this procedure in which we collect a sperm. We'll try and take it from the sample which you have provided. But if it's really not possible, that then we might have to take a small tissue sample, and like by numbing that area. All right.
Mm-hmm.
And then when we take the sample, we also at the same time, uh, we even collect the egg from your wife, and we'll try and fertilize this. And that is one way how we can go ahead with you having a child of your own.
Okay. All right.
Yes.
Okay, fine.
Yes, Mr.
Mm.
James. So that is
So,
that one way of how we can go about. But
mm,
it's always advised that we just go ahead with these investigations first to get to the root cause of it.
mm. So these steroids I had taken back then could have a permanent effect as well.
Actually, yeah, it does have in few percent. Most of the time, when you stop steroid medication within a period of 12 to 18 months, it is said that the sperm cycle, the normal production of sperm starts again. But the one concerning thing which I see in your history is that you had stopped it abruptly. It is always told to stop in stop like in tapering doses. So that is the only concern I have here. And yes, you know, we'll just get to know why
Okay.
this has happened. Yeah. Any other concerns you have, Mr. James, apart from this?
No, anything else I need to know?
Yes, just in case, if this procedure do not really work out, and like um, we can actually go ahead with other options. Like you would as well have other options, like adoption and also foster care. Like these are the last options. I'm sorry to be saying you all of these at this point in time. I know that's
It's
a lot
okay.
of
Yeah.
information to be giving. Yeah, I'll do one thing. I'll book in your investigations, and also book in your next appointment with my consultant and also the fertility specialist doctor, and probably
Mhm.
give you some information leaflet on what's happening and all the thing which we just discussed. If
Mhm.
at any point you have any further queries, you can contact me or your GP. All right, Mr. James.
Yes, sure.
All right. Thank you for your time.
Thank you. Okay. Any reflections, both of you, Dr. Radhika and Aisha?
Uh, Probably I missed a few things. I forgot asking sexually shared infections. I don't know.
Mm-hmm.
I probably I don't probably the management plan I couldn't really give properly.
Uh,
Yes,
all
ma'am.
right. What do you think you would have done differently if you're given now to introspect on the task that you just performed?
Yes, ma'am. Probably I don't know, ma'am. My brain is not working.
Okay. All right. Fine. You have done quite a good job. Okay. So, what about Dr. Radhika?
Right, ma'am.
Is she here?
Yes, ma'am.
Did you join through some like other?
Yes, ma'am. Actually,
As a,
it's hanging on my iPad, so I've switched on to my mobile now.
oh, okay, good. All right. What do you think?
I'm actually I got confounded when you suddenly said that you take steroids, and I
Hmm.
was seeing the hormone levels and the testosterone levels. It made sense that something hypothalamic is going wrong. It's pre-testicular. But when
Okay.
nothing was going on, there was no anosmia, nothing. I was trying to rule out all the causes, any from pituitary, hypothalamus, then testes, everything I was trying to
Mm,
rule
mm,
out.
mm, mm,
And
mm,
even the hormone, the steroids also I asked in the beginning. I am not sure that in such stations, am I supposed to press upon him that you mentioned that you are more gym oriented person? Can you
mm,
please tell me if you take steroids or not? Should I have focused more on
mm,
that, ma'am?
mm. I'm gonna come to that. Okay. So basically, but you do see the difference, glaring
Yes.
differences between the station one and station two, okay, which have both appeared in like I have also given my own tweaks inside the stations, of course, that we know that the famous old recall which had come with this had an individual who was supposedly without his knowledge taking some supplements in the gym, but is not aware what it contains. But in this particular case, yes, I'm quite uh, very much aware what I'm taking, and I know that I'm taking steroids, but it's kind of not allowed. So I don't want to talk about it initially, but when you say the right things in the station, usually the role player then tells you. For instance, if you've noted, there is a station in which there's this girl with type 1 diabetes who's having macrosomia, HbA1c is high. Your reports are all pointing towards some sort of a bad control, but she keeps denying that there is anything. Okay. And then how you have to basically elicit what is a sort of hidden agenda in these stations is say the right things. So, what do you think you can say to an individual who is doing that in that station? And I'll tell you how you know whether to press for that particular history or not. It's actually quite simple. Okay, so in case there is such an agenda, what would you say? What would you have? Now that I've told you that this is the thing, How would you elicit this?
So I would just say that, Mr. James, I understand that you are quite upset and you want to conceive a baby. Have conceive a baby. It would be really, it would really be appreciated if you are able to share all the information accurately. That would help us formulate a better management plan for you. I don't know.
Okay. What else? What else? Think. What did you say to that girl
Any
when?
medication? Yes, ma'am.
One is the fact that you're
Confidentiality,
telling him.
ma'am.
You need to, yeah, one is confidentiality. As I go through this presentation, I'll be telling you all the essential things you need to do in subfertility for all cases, obviously. But uh, one of the major things in terms of communication, how you elicit something which a role player or a person doesn't want to tell you about, is tell them the harmful effects of it. Isn't that what we do in domestic violence? It's the same thing that we do in cases where there is any sort of abuse, there is bullying. We say, okay, of course, whatever will remain between you and me, I assure you that it will be confidential. Secondly, what are the effects that this thing that they are, you strongly suspect that they are doing is going to have on their condition. So not only is he taking steroids, which is quite evident from the fact, see, this is not correlating with each other. All right. If FSH is low, okay, and sperm is low, what does FSH and LH do? They go and they stimulate the Sertoli cells for sperm production and Leydig cells by LH for testosterone production. That's their job, isn't it? So if this is low, this this can be low. This is also supposed to be low, right?
Yes, ma'am.
Okay, there is suppression. So in this situation, you're not finding this is high, so it's not correlating. You know very well that there is free testosterone coming from somewhere else. Androgen is coming from somewhere else, and he's not having any other hypoandrogenic symptoms. If there is hypogonadotropic hypogonadism, as you said, pre-testicular, then a person with Kalman syndrome, okay, what you are asking about anosmia, a person who has headache, or I know you were looking for prolactin secreting tumors and suppression there and there. If that is there, then this individual will also have a lack of testosterone and will present with other symptoms such as loss of muscle mass, weight gains, lack of energy, lack of libido. None of these are there. Okay. And the only explanation for this is testosterone is coming from exogenous source or an endogenous secretion from somewhere else, like a tumor or something like that. But in which case it would have been in the range of thousands. It isn't. It's high enough to suppress this, but not high enough to suggest to you that it's being secreted by an endogenous entity, okay, free from any suppression. You understand? So your diagnosis, Radhika, in
Yes,
station
ma'am.
one, your diagnosis is already provided to you. You just have to know how to interpret the result. Your entire basis of that template of history taking, which would point you towards childhood mumps or anything else, cystic fibrosis, if you're looking for post-testicular cause like a blockage or anything, does not make sense with attached investigations of this sort. That is not the case in the second station. Okay, in the second station, we haven't given you the FSH and the testosterone level. You know nothing about the hormones of this individual. You cannot make a diagnosis whether it's classification 1, 2, or 3. And therefore, you need to ask an entire template of history, which Dr. Aisha has done. Okay, so there are some things which are, of course, to be added in that history. We will come to that. All right, but you get the difference in the information gathering in the two stations. Is that clear?
So, ma'am, in station one, we had to just ask a focused history relating
Very
to
much
just
so.
yeah,
Yeah.
just around the steroids, not the
Yeah,
generalized.
main agenda
Yes.
of station one is eliciting a hidden agenda of the station, and then proceeding
Okay.
those who are able to elicit that and get that from
Mm-hmm.
the role player, get the role player to admit that this is the thing, and then tell a management plan. Again, the management is also quite different. Okay, management in both stations is quite different. They look very similar, but they aren't.
Mm-hmm.
So we'll just do a brief thing on these are my role player instructions. So let's not go there. But we'll go through how to look at male fertility or subfertility in general. Okay. So when it comes to subfertility tasks in general, there are four things I want everybody to remember. Okay. All right. So everyone here with me?
Yes, ma'am.
Lavana, Dr. Indu,
Yes, yes.
Lakshmi. Okay. So the first thing is remember always that subfertility is a couple issue. Okay, it's a couple issue. So partner is essential to be evaluated. This I'm not giving you feedback for this station, but I'm telling you in general how to look at a subfertility station. Okay, so it's a couple issue. Partners essential to be evaluated. In most times in RCOG stations, it's going to be a specific thing that you're dealing with. So usually they will provide you with the partner reports, or when you ask the role player, was partner evaluated? What was the thing? They will tell you that yes, I know that it was normal. You have to take it that it is normal. You have to consider that it is normal. You've done your job of asking for it. If it isn't provided in your station as such, okay? So whether they are provided or not, if they are not provided, you would need to take a detailed history of the partner and advice. But this is not usually the case because the station is just a 10-minute thing. So you cannot take that extensive history of both, right? So
Okay, ma'am.
if they are provided, if the female partner is provided, you look for an abnormality, which usually it will not be there. If it is normal, the only other question that remains is the sexual history. Okay, whether y'all are having intercourse regularly, how often it is there any difficulties, okay, with intercourse? Because if this particular partner's abnormal reports are there, and the female partner in this case was normal, then the only thing is whether the sexual history is there. If that's confirmed, then it should not be an issue. There are some things you can ask for both that I'm going to come just in a bit. Okay, that's point number one. It's a couple issue. Second, it's a chronic issue. Okay, so it tends to have an effect on the mental health. All right, it's not wrong to offer counseling before any mental issues will arise in this individual. Okay, so as a general rule, we would advise subfertility couples. You can just say that, we understand that have been going through this for a long time and can offer you counseling. That's something both of you have done, so that's okay. Marital issues may exist, like you need to ask how the fertility issue is affecting their relationship. Okay, just like how in Eurogyne we always say quality of life, how it affects you in general. Okay, find out about these things. So in this subfertility, always any station, these are things that you have to remember. Now, treatments have major financial, legal, and ethical implication. Point number three. All right. So explore funding criteria always. It's not enough to ask if he has fathered a child. You always have to confirm if the female partner also has kids. All right. Just like for
Okay.
females, you will ask if you or your partner have had kids. The same way.
Okay. Okay,
Anywhere,
ma'am.
things like these may be hidden. All right. So, if they are not eligible for the funding criteria, what are the funding criteria, by the way, just for completion's sake?
They should not have children either adopted or their own children from
Hmm.
this marriage or any previous relationship.
Great. Then, what
And
else?
the BMI should be less than 30 of the female partner,
Hmm.
and the age also, the age should be less than 40 for the woman.
Less
Yeah,
than
And
35.
that, okay.
less
No,
than
no,
yeah, that's
yeah.
enough.
No, 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 no. You're talking about BMI, right?
BMI 30, ma'am.
Okay. And age you
And
said less
age,
than 40. But IVF has criteria of how many cycles can be offered between 40 and 42 as well.
sorry, one
So
cycle, yeah.
it's not always,
42.
yeah, one cycle can be offered. So it's not, you can right to say that beyond 40 it will not be offered. What else?
And the AMH and the levels should also be taken.
Mm, No, no. Funding criteria. Very specifically, I'm
Okay.
asking funding criteria. Smoking. Okay. They
Yes.
both have to be non-smokers. Okay. So majorly dependent on your both partners, you need to ask the BMI and of course age, and you need to make sure that they don't have any children and non-smokers. Okay, these things you need to ask in all histories in subfertility to explore funding criteria. Remember that, okay, remember always that it's not the role player's job to come and ask you if their treatment will be funded. It is one of the patient safety points for you to bring it up. If you do a consultation with them where they are not eligible for funding and you don't tell them that, that's an error on your part because they are assuming that the treatments that you are discussing with them are going to get funded. So if you discuss IVF with a person, okay, you need to tell them that this will not be available. They might have to fund on their own, or you will write to that CCG group, which that typical advice that we have. But I'm just highlighting why this is an important point. It becomes a concern for patient safety if you have not brought it up. Sometimes role player may not ask a leading question about it. Okay, so second is whenever there is any funding issue, do not forget to speak about reproductive tourism. Okay, why? Is because you may write to CCG and they may not be funded. If that is not, then you have to provide them with there is an alternative option of going ahead with these treatments somewhere else. Okay, some couples do choose reproductive tourism where they travel and then they can get pregnant. Okay, which may be cheaper. All right, but do go through the legalities before going ahead with this trip. So that's something. Okay, not particular to this station. Again, I'm reminding you, please do not get confused later saying that in this station I told you to tell about reproductive tourism. No. Okay, I'm telling you in general. And child safeguarding issues you need to look out for in stations which involve single parents or same sex couples going for higher treatments. Okay, by this we mean that an unborn child born through these IVF, etc., treatments, okay, it's the ethical responsibility to look whether this child's interests, okay, after birth are safeguarded or not. So there are agencies which will look into the financial standing of the parents who are planning to have the child, okay, and so on and so forth. And with donors, you have to know about legality, like what happens to donor anonymity. For instance, after 2005 in UK, we do not have donor anonymity, which means that they can find out who the donor egg and the donor sperm came from when the child becomes 18 years of age, not before that. Okay, before that, the parent will not have any identification, but yes, the child can find out. This is not true for all of Europe. For instance, in Spain, in Greece, which are very hot destinations for reproductive tourism, donor anonymity still stands. The child will never know their biological parent. Okay, so yeah, so that is point number three. And yes, consultation is very intimate. So always signpost and assure confidentiality. So all subfertility stations, I want you to remember about all these things so that you do not skip out on anything. Is that clear? Yes, Radhika, Aisha,
Ma'am,
others?
ma'am, and
Yes,
in the
ma'am.
stations, was there a role of examination as such? No, no, ma'am.
Which one was yours? Yeah.
This,
The
the second
no,
one.
see, if
Yes, ma'am.
no, would say you can mention about examination and say that you would be examined by a specialist, because you would have to send
Mm-hmm.
these for either andrologist or a urologist for examination. Okay,
Okay.
but as
Okay,
such,
ma'am.
what you said, I'm very happy with the way that you performed. I'm not complaining at all. Okay,
No, ma'am.
so that was
Just to
good.
rule out varicocele or something.
No, I'll tell you. I'll tell you. I'll tell you.
Okay.
Okay,
Okay, ma'am.
so now basic in when you're looking at a male subfertility station, there is no excuse for not knowing normal semen parameters. Okay, through analysis, you have to see whether which parameters are altered. Okay, usually it will be the concentration which will be given to you as very low. Okay, total numbers may be low, semen may be volume may be normal, and all of them together usually will be given to you as low. See if there are abnormal forms or normal forms. All right. If the teratospermia is there, it is likely, okay, that there is something which has been very damaging to lady, sorry, Sertoli cells. Okay. Therefore, the produced sperms, whatever with whatever stimulus are there, are being formed abnormally. Okay, so
Mhm.
that can point you towards testicular problems as such. Okay, rather than with a steroid inhibited person, you may mostly have a reduction in the numbers, but not too many abnormal forms. Okay, with permanent and long-term steroid use, you can get though. Then again, we are going to look at, yes, the causes. So pre-testicular, testicular, post-testicular, obstruction related. So if there can be Kalman syndrome, which again, history you asked me, then tumors, radiation, surgery, pituitary insufficiency, hyperprolactinemia, anabolic steroids, okay, glucocorticoid excess, thyroid abnormalities, etc. And in testicular, we have other genetic causes, okay, cryptorchidism, varicocele, surgeries, trauma, torsion, orchitis, chemotherapy, radiation, and testicular tumors, etc. These are all your testicular causes. And post-testicular, there is obstruction from whatever reason it may be. Okay. Now, how you essentially how you essentially know the difference between these three. Let us wake some people up.
Ma'am, I had
Dr.
a doubt, ma'am.
Yeah, yeah, sure.
Ma'am,
Tell me.
that the WHO levels of the normal sperm count, that's like the 2013 version. Should we follow that since it's given in NICE, or should we follow the 2021 update for these?
I feel that since it's there in the NICE guideline till the update comes up, that we can stick to it. But
Okay, ma'am.
in your from your part three perspective, the in the stations, it will be a glaring thing, right? It will
Mm-hmm.
not be something which will be undiagnosable based on any of
Okay,
the
ma'am.
standards. Huh? So
Okay,
you
ma'am.
don't
Okay.
have to worry about that. There is no nitpicking involved in this thing. Like I'm going to be
Okay, ma'am.
the gross thing which is going to be there. Usually the
Okay.
stations get complicated in your mind. All right.
Okay, ma'am.
So you
Okay.
have to know that. All right.
Okay. Thank you, ma'am.
So yes, how do you know difference between pre-testicular, testicular, and post-testicular? Radhika, you said.
Okay, ma'am. In pre-testicular causes, the cause can either be in the pituitary or the hypothalamus or
No, no,
adrenal or thyroid. Yes, ma'am. So
no.
hormone
How
levels, ma'am.
how do you hormone level? So what will be what? That's what
Pre-testicular
I'm.
is hypothalamic, hypogonadotropic hypogonadism. So both
Okay.
LH-FSH will be low and the testosterone level will also be low.
Except when you take
Except,
anabolic steroids.
yes, except
Or
when you take animal.
except when you take anabolic steroids, which is what was happening in your station.
Yes,
So
ma'am.
the whole thing was based on your applied clinical knowledge point and your patient safety. One of the major things in that station was to establish what the diagnosis is based on what you have been given here. Okay, so that's something which you have to remember. Hmm? So let's go to the how to make a diagnosis. So everybody has to remember, okay, how At a glance, you are supposed to know what is wrong with the patient if these things are given. If these are not given, it becomes a part of the investigations that you are going to advise the patient. You'll say, we need to see more on the FSH-LH and your free testosterone level, on basis of which I'll be able to tell you what it is, whether it's where the problem lies, whether it is in the production of hormones which stimulate the sperm, or in the production at the level of the testes, or is there any blockage of the testes. So in lay terms, it's as simple as that. You just need to
Ma'am, I
tell
have
them.
one more doubt.
Yeah, sure.
Ma'am, when we go on to ask that we will be doing some further investigation, so should we specifically tell them that we call these the FSH, LH levels and the prolactin? Like we have to tell the patient about the names of these tests which we'll be doing?
No, see, you don't have to. You may. If you do,
Okay.
you have to immediately tell what it is because you're talking to the role player. If you
Yes,
don't
ma'am.
tell and you say what it is, like in lay term, examiner
Mm-hmm.
is still marking you, right? Examiner
Yes,
knows
ma'am.
you're talking about FSH and LH and testosterone.
Okay.
So they're going to
Okay,
mark
ma'am.
you regardless. If you say that I would want to test you for the male hormone
Mm-hmm.
and also hormones coming from your brain which stimulate this, then also
Okay.
examiner knows that you're talking FSH-LH.
Okay, ma'am.
Well,
Got
you've
it.
used lay language, that's it. So if you're telling FSH-LH, how you will say it differently is that we need to do some more tests which are called as FSH-LH level, which is stimulating hormone from your brain, and testosterone, which is the male hormone. That's it. It's just
Okay, ma'am.
a different way of saying. I personally prefer saying FSH-LH and explaining what it is immediately,
Okay,
like
ma'am.
using the medical term and then telling in to be very specific.
Yes, ma'am. Thank
Okay, so yeah. So then if everything is normal, all hormones are normal, its production, everything is normal. Testes are basically functioning fine. It's after the testes that is in the tubing problem, so obstructed. Okay, and if your FSH-LH is low, but testosterone is high, it is exogenous steroid. Okay, rare, very rare testosterone secreting tumor from somewhere else, but usually exogenous steroid. Okay, so and as a general rule, if you have read the subfertility guideline and the male subfertility talk as well, you would know that you have to advise them about lifestyle, all right, like optimizing weight, smoking, alcohol, exercise, and healthy diet. These, whichever ones are applicable, you will pick and you will tell them that these are the things you need to follow. Okay, and about sexual frequency being 2 to 3 times in a day. Okay, all right, these are general things. Now let's come to these particular stations. All right, this is Dr. Radhika's information gathering related. All right, okay. Any weight changes and hair changes is a pertinent question in this. The reason being the testosterone itself, okay, steroids which he is taking, and the steroids you know are exogenously coming, or may be responsible for a bulking up effect which is there. Okay, hair changes may also be there. For instance, there may be hair loss. Okay, there are also a lot of mood changes in these individuals. For instance, aggression increases, sometimes even depression, and the testosterone has other effects like causing I think I mentioned aggression, and sometimes a long-term effect can be with leading to psychotic rages, and all of those things may be there. So you need to ask about mood changes. Apart from that, as I have told you, that there is an effect of a chronic problem like subfertility on person's mental health. Okay, so instead of asking, have you been feeling down, depressed, low, in these stations, how are you and your partner coping with this issue? Okay, is another better, slightly nicer way of asking for these things. All right. You ask about how they are coping. They say it's fine. It is considered under. You have checked on the mental well-being of the person. Okay, everybody. Anita, Dr. Anita. Okay, fine. All right. Sexual dysfunction you need to rule out as a part of all subfertility, and uh, partner history in the female. Okay, there are some important things. You know the reports were normal, but you can ask, is she generally fit and well? This is one question you can add to know grossly if there is any medical conditions that she has had. You know that she doesn't have any blockages, etc., etc. HSG was normal. Okay. Again, those things you don't need to, dig into because you know ovulation is occurring. All right, based on the progesterone which is provided to you. So, and smoking and BMI. This two important questions are again because of the uh, funding criteria. All right. And have you or your partner have had any children? Okay. Do you or your partner have any children? That's an important question. All right. This smoking, alcohol, drugs is a part of your template for the male as it is. If you do not know the BMI, ask for the BMI, and funding eligibility I have mentioned, and financial stability is an SOS question. SOS is in wherever you are finding a person who is not eligible for IVF funding. In that case, you have to ask about finances. Is that clear, Radhika?
Yes, ma'am.
Coming to Dr. Aisha's information gathering. Okay, so very good, very well done. Almost everything was there, except the partner related questions, the partners, the funding criteria, etc. That was a little bit which was missed out. Otherwise, pretty much you covered, touched upon mental health, sexual problems. You did ask STI. You asked me something about cloudy urine, etc. And
Yes, ma'am.
I don't know,
I
some
was
symptoms to be
retrograde ejaculation. Yes, ma'am.
maybe, but let's
Yeah.
uh, consider, maybe you can ask for discharge if you're considering currently
Yes, ma'am.
asking about symptoms of current STI, or you need to ask
Mhm.
about have you had any sexually transmitted infection in the past. It's very, very, very important. Injuries, swelling in the groin region. You were asking
Mhm.
me for varicocele, isn't it?
Yes, ma'am. Any
You can
GP or
just ask this
surgery?
question.
Yes, ma'am. Yes, ma'am.
Do you need to examine?
Yes, ma'am.
You don't need to. So that's why I
Okay.
was telling you I'm coming to that. You can ask this
Okay, ma'am.
question of swelling, these surgeries and
Okay.
the groin, right? To your,
Okay, ma'am.
rule out your varicocele. Now, weight changes, hair changes, excess breast tissue. Sometimes you can get, gynecomastia, these sort of problems with hypogonadism. Since you didn't have the reports, you didn't have the hormones, that's why your station was harder in terms of
Mhm.
the history taking. It was a lot more detailed than the other
Okay.
station which was there.
Okay.
So, chronic illnesses, acute illnesses, occupation also you asked me. I'm very happy you asked radiation, chemo, exposure, genetic conditions, and family history. A family history of difficulty in conceiving in the males is also
Okay.
something which is relevant. Okay,
Family history.
okay,
Okay, ma'am.
alrighty, done. And cystic fibrosis that which you asked about the chronic coughs, etc., etc.
Yes, ma'am.
So good, good, good efforts.
Thank you, ma'am.
Yes, would not be wrong because fertility station this person when he has never been examined, you can arrange an examination. You could say we would need to examine you and we would need to give you some more tests in that station, in station number two, some more tests to know what exactly is the category of the
Mhm.
uh, problem with sperm production, right?
Okay, ma'am.
Communication, both would have the same points, including introduction. The first one I have done as a Breaking Bad news. However, in the second one, okay, He was kind of all right. He was told by the GP. So that was one thing which was lacking is like what has been told to you about the
Okay,
first
okay.
report. So I was quite aware that my first report was abnormal and was anticipating that there may be something wrong now. So it was kind of like not so much of a BBN. I was not very shocked if you notice in that, right? When you told me about the report, there's a lot of disturbance coming from somewhere. Once again, let me mute all. Okay. So it was not like a Breaking Bad news station in that sense. Okay. So of course you have to say that I'm going to give you a lot of information and then proceed with the template. But usually role player was taking it well. It was not something of a shock. Next is using of lay language, which both have done very well. Body language, we need a camera to assess. Chunking of information, checking of understanding intermittently. Okay, am I clear to you? Is there anything else you need to know or ask? Right. Signposting before sensitive history. As a general rule, what we always teach is in subfertility and in sexual and reproductive health. Please, okay, just to make your life simpler, signpost and assure confidentiality in the beginning of the station. There are going to be lots of role players, lots of hidden agendas for you, wherein they wouldn't tell you certain things. Or there is because it's just a good way of communicating with an individual if you tell them that whatever this consultation is going to entail a lot of personal details, but they will remain between you and me. And instead of going there just before sexual history, okay, so that it builds a sort of rapport in the beginning of the station and it makes the role player more at ease to start talking about their issues. So primarily if they want to talk about some sexual dysfunction in the beginning of the station itself, also it will become easier for them. Okay, so just as a general rule, do these two things before starting anything else in that station. Okay. Next, when you are going through your history template and you reach the sexual history, then you need not use a longer signposting statement there. You can just say that just some personal questions and then go ahead with your question. All right, because you've already done that in the past. So you can just mention that and you can ask your rest of your history, okay? Sexual history specifically. So that's a very important thing you're going to be marked on in communication in these particular modules, and you have to always remember to do that, right? Again, you're both non-paternalistic, non-judgmental, and neither of the cases were. Coming to Dr. Radhika, you here?
Yes, ma'am.
Hmm. All right. So you were asking me, how do you elicit, right? Have you thought about that now? How do you elicit?
Yes, ma'am. In the beginning only I should have said.
You say, and then what else? I'm still not telling you that I take. I know that it's illegal, so I'm not telling you. I'm not telling you. I'm scared.
Okay.
So I'm just not telling you. I'm very resistant. What do you do?
uh, in order for us to reach a diagnosis sooner and help you and your partner have a baby, it is necessary for us to get all the facts. So if there is anything else you would
You're
like to
just
share with.
you're accusing me of being a liar, basically. Isn't okay? Anything else? Uh, yeah, that's good. A lot of good attempts, but this is something else. I mean, what you have tried before in stations in the past, you've used it before. It's not that different. It's all the stations are going to be like similar. Approaches are very similar, not different. Anyone else?
Ma'am, can I try?
Arheen? Yeah, sure.
Ma'am, talk
Go
about
ahead.
the negative effects like effects of steroids on the patient, like he can have a liver damage, baldness, high blood
Mm,
pressure, clot
okay,
formations. So that
right.
will be helpful.
Yeah, okay. So you need to tell when they don't, when you want them to stop a behavior, you need to tell them full information about what they're doing. right? Tell them what can happen because of continued use of steroid, right? Because you've caught them. You basically, based on the reports, you know what it is. Okay, so you need to just get that admission. How you do that is the same way that I was just talking about that type 1 diabetic. What do you say? If you don't take your insulin properly, the baby can grow bigger, smaller. You can, have microsomia, difficulty, bleeding at the time of delivery, life-threatening condition. Okay, baby can die, mother can die, complications like decay, etc. arise, and then she'll say, "Oh my God, I didn't know all of this. Okay, I didn't know all of this, and I was telling you something else." So similarly, when you know the thing, and you have to be for this reason, you have to interpret the reports confidently. You should have that in your hands. Okay, hold all the cards, and then you should be able to try and go. The agenda was very, very different in both the stations, if you get what I mean. The second one is more of a clinical one, and the first one was more of communication and all of that based. Okay, so what you do is after your history is done, which was pretty short here, you need to tell them that confirm. Of course, this was I think I've written this one wrongly here. It was the second sample. So you need to tell them that yes, it's confirmed that there is some issue with the sperm and that's not there. So it looks from your reports uh, what the reports say, how you interpret the report. You need to tell them. Okay. How you go about doing is normal testes. Always say what normal is first. Okay, so normally the testes produce sperm. Normally the testes produce testosterone hormone by different cells and based on the signals it receives from your brain. It is seen in your report that the sperm production isn't occurring. However, the testosterone hormone is still intact. The signals coming are quite dampened. Okay, this can occur with the steroids coming from somewhere else. Okay, so you tell this, it's like a hint. It's somewhere else. You're not calling them a liar to them, their faces, but you're telling them that it's coming from somewhere else, either from in individuals who take it from externally, or sometimes there can be rarer cases of tumors which produce this. We'll have to evaluate that. Okay. What you need to understand is this androgens, if they remain high in the body, then even they can have a lot of mental changes on the individual, causing aggressive behavior, sometimes mood swings, depressions also. Okay. Sometimes they alter libido as well. All right. And in very rare cases, even psychosis has happened. It has other health effects like high blood pressures, okay, accelerated in fact, and in on your effect on your heart rate, okay, clots because of, as she mentioned, erythrocytosis can occur, okay, and basically heart can be affected in the long term. Liver and kidney also can get damaged because of long term usage of steroids. So if there is something that you need to tell me at this point, then of course the agenda comes out and, oh my God, I was not aware of these things. You tell them, okay, fine. What we do is we need to look into what dosage you're taking right now. We need to coalesce with all these MDT people and andrologists, etc., and our fertility specialist, of course. And what we are going to do is we have to slowly taper them. All right. So not at once, don't stop them immediately. Just because I'm saying all these things, don't stop them immediately. We'll taper them and we'll tell you how to, wean off of them, because if you stop them, at once, you may get withdrawal symptoms. All right. Now, about fertility, you talk then. So you have to tell them what are the effects. So usually, more often than not, the effect of steroids on the sperm production is reversible. More often than not, it is reversible. So you need to tell them that. I think someone said that it comes back in 12 to 18 months. May I know from where that information is? Can you quote a talk or something?
Man, I
Because as
just
far
read
as I know.
somewhere, I don't remember.
I mean, TOG 4 to
No.
12 months. Yeah.
Yeah, it's not 12 to 18 months. It's 4 to 12 months. There are several articles which quote the same figure. Because about 4
Okay.
to 12 months usual. The long-term effect which is there, which after 12 months if it hasn't returned, then even as late as 4 years, they can still have normal sperm production. If there's a long-term effect, no? It can either be permanent or a very delayed thing.
Okay.
Reversal is there. Can happen.
Okay.
So you need to tell them that usually, and the sperm cycle again, you said of it is about 12 months. I don't know if you mistook it or just uttered something wrong. Be
Probably
very
I did
careful.
wrong, ma'am.
So,
Okay.
yeah, so it is 3 months.
Yes,
The
ma'am.
cycle of production is 3 months.
It's
You
three
need
months.
to
Yes, ma'am.
tell that. Yeah, you need to tell that when you stop, new sperm will start being produced when your stimulation will brain stimulus will start, and then as the new production starts after 3 months of that, we can check it again, and it should usually return to normal, and then you can try to have a baby naturally. However, there is a rare possibility that there is a long-term damage, okay, if the sperm count doesn't come back to normal, in which case we have certain options. Would you like to discuss that? So now at this point, what are you doing? You're exploring what my station is about. All right. You've told about the basic line of management, and then you need to ask them, okay, where are my applied clinical knowledge points now? Okay. So your role player is going to tell, okay, yes, tell me what are my options. Then you need to state the options, ask them, what would you like to talk about? Right? See where they are taking you. They usually want to discuss more about, okay, tell me more about test tube baby, or they have some specific questions in their templates where they will try to guide you about. Okay, that's how it usually goes. So what you will do is tell them that if it doesn't and it's a long-standing problem, then also we have certain options. I think again, then someone said that there is because of your abrupt stopping. That was in the next station. Of course, we'll go to that a little bit later. Okay, Radhika, which scan do you do to know if sperm is being produced in the testes?
No, ma'am, I wanted to talk about the retrograde sperm only. That is why I was saying the transrectal ultrasound. Yeah. That was only for if the sperms are getting retrograde, not for production.
But you said production to me, and you said
No, no.
we will do a scan. This is what you said. I'll tell you. I don't know if you remember. You said uh, what we'll do is we'll do a scan to see if sperm is being produced in the testicles at all, and if that is so, then we'll be able to retrieve it. Are you talking about the this or a
And
biopsy
I
or
was
something like
told obstructive azoospermia, and that the sperms, if they are, we cannot actually see.
that? Okay, fine. See, don't get confused between the different etiologies. In your station, primarily etiology was quite clear from the report. Okay, so that's why you don't have to talk about things here and there, and don't get distracted with other issues. Okay, um, what you need to say is if the sperm production doesn't return after this stoppage of steroid, then what we do is we do a biopsy, see whether production is altered or not at the level of the testicles, right? If at all you're able to see any sperm, okay, or we are able to retrieve sperm, then there is a possibility of going for a test tube baby, okay, wherein your partner's egg is taken and after stimulation, and your sperm will be directly injected into it because it's lesser in number, and the resultant embryo will be then put back in her womb. Okay, that's the simplest way, one line sentence to describe ICSI with IVF. Okay. If at all these cycles do not succeed, or it is deemed better to use a donor sperm for whatsoever reason, maybe the quality of the sperm is not good enough when your fertility specialist sees that and finds out that maybe that's not an option, then the sperm can be taken by a donor sperm, and the third option is to go for adoption. Okay, So these are some of the alternatives for them. Remember, if any issues from your history, if you've elicited for funding, etc., you immediately make a note of that, like write in your notepad, funding has to be mentioned. Okay, so when you write funding, it's in your brain, it has to be code for, I need to mention this is not funded, and I need to talk about what?
Fathered or mothered to form.
Clinical
No,
commission.
Smoke.
clinical commissioning group and
Smoking
tourism.
by the participants. Tourism, yeah.
No, when same management, when you say, okay, funding is not being there in the history, okay, so that's your information gathering bit. That is done already. Now, if you've forgotten to ask these things, then later on you remember while you're discussing management, still not wrong. Go back and you can ask about, criteria. If you've missed out on anything, you can always do that. But so fertility stations, please remember always all of these things are going to be present in your template. Okay, and you need to ask. Okay, right. Then we have the long-term effect can reverse even after 4 years. All right, if he has no sperm production at the end of this, he goes through a treatment, takes donor sperm, for example, and they get pregnant. They're happy. The male thinks this guy James thinks that he cannot have a child. Then suddenly one day his wife is pregnant after 5 years. What have you not told them? They need contraception later. Okay, doesn't mean that it's always going to be there. It can be reversed also. So that's again very, very important patient safety point. This is very similar to how in POI stations you tell them if you don't want to conceive, it's not like you are sterile. Okay, this is subfertile, not sterile. So she needs to use some contraception. Got it?
Yes, ma'am.
Okay. All right. Let's go to the next bit, which is your Dr. Aisha's uh, patient safety and applied clinical knowledge points. Most of them, the points overlap. Okay. However, so as I've said again, I've mistyped here. This had to be in the previous one. Okay, sorry about that. So it was the first sample, so you need to confirm the diagnosis, okay, with your FSH and free testosterone, and advise further evaluation for what is the reason for this particular thing. Counselor, as I mentioned, fertility specialist and MTT. Always, both of them have checked the name and NHS number on the reports, so that's there. And you have your confidentiality, which you're doing right in the start of the station. Okay, so no mess will happen through any station. And could have been the steroid intake. You need to say that yes, from your history and all of that in your report, it is showing no sperm production, but this could be because of the steroid, which can have a effect of damaging the sperm producing cells. Okay, but it could be other etiology as well. Okay, including obstructive. Now, the reason I'm more leaning towards obstructive, can anybody tell me based on how we performed as the role player and from the history taking? There were some things which hint that a hypothalamic cause isn't there. Aisha, can you think about what it is?
Ma'am, hypothalamic was
Yeah,
because
in
in
hypothalamic,
history,
what else?
you were asking like any breast mass. So probably that
No,
question
you've
was,
asked the history. You knew based on
yeah,
certain history that not he's not one of the hypothalamic causes. Now, hypothalamic basically have hypoandrogenic symptoms
yes,
also.
ma'am.
There'll be a lot of
Oh, yes, sorry, ma'am.
lack
Obstructive
of
causes.
energy, weight gain, lack of energy, lack of libido, maybe erectile problems. These issues will arise because you know that that their testosterone is also low, no?
Yes,
So
ma'am.
that's always there. So
Obstructive
apart from
cases.
obstructed, nothing else will be wrong. Nothing else will
Yes,
be
ma'am.
wrong.
Okay,
Okay.
okay,
So
ma'am.
similarly, this patient, either
Mhm.
it's going to be that or one second.
Obstructive cause.
One second, I'm getting a call. Up. Hello. No, I'll finish. Hmm. Okay. So, hmm. So if it appears that so you do a further evaluation, okay, and it could be either this or obstructive. If it appears that sperm is available in the testicle, then we could try to retrieve it. In obstructive cases, we also have an option of performing a surgery, which will be discussed not at your level. These are not your things to talk about, but you have to put the potential options ahead. You know that these are super specialty things, so you have to just touch upon the basics in these stations, and you have to know the baseline or the outline of treatment, what are the options and how things are to be done. That's all. So you say that a similar line of management will be there. If it's non-obstructive and still there is going to be lack of sperm, right? Then means that there is some damage because of the past steroid he has taken, can happen, okay, and it has been very residual effect has been there. It's not because he has stopped it abruptly or anything like that, huh? It's that he has stopped, he has not gotten any withdrawal thing. Abrupt stoppage, the only thing you why you don't do it is to prevent withdrawal issues associated with it. Like they can suddenly get very low energy, depression, all of these things can happen. Libido can be lost. So you don't want that
Okay.
effect. So that's why you want to taper it. That's the only issue. Okay. And
Okay, ma'am.
all right, let's see what else I had wrote down. Something. All right. Hmm. Then we have the donor sperm option, adoption option, as we have spoken in the earlier station, and counseling, writing back to GP, giving patient information, leaflet, support groups, consultant, okay, fertility specialist, all these things we have spoken about. And as told in the first station, long-term effect can sometimes reverse even after 4 years. So it means that subsequently then, whenever, if he doesn't want to conceive, okay, by accident, they have to use contraception. All
Okay,
right.
ma'am. Yeah.
Okay. So I think that's it. Any other doubts, Aisha? No.
No, no, ma'am.
Ma'am, I
It's
have a
pretty much clear.
doubt.
Yeah, tell me.
Ma'am, about the confidentiality thing and the
Yeah,
partner's reports. If at
correct.
all he already knows, then that's fine. If he doesn't know and the partner's reports, do we have to ask him? Do we just have to tell him that we cannot discuss the reports with you at the moment and we need the partner's presence and their consent to discuss the
Why?
reports?
Why? Why?
If he, and that's what I'm confused about. If the reports are normal, can we
See,
discuss? If abnormal, we cannot
no, you
discuss.
no, no,
What?
no, no. You cannot discuss any reports of any other
Yes.
individual without that individual's consent. Okay. And if he hasn't asked you, why you want to bring it up that no, 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 your partner's report, I'm
If,
not going to
okay.
tell you. No. If he asks you, you have to politely decline it. It's a
Okay.
different thing. But yes, the reason is that he will ask you if it's an agenda in the station. So they are testing whether you are safe, you are confidential or not, whether you know about confidentiality or not. That is the reason it is put. You don't have to like throw it in his face that you can't. No, your partner's report I have, but you can't see. Like you don't you don't have to do that. Okay,
Okay.
so it's not like that.
And if he
Okay, if they
says that
ask
my
you,
is, even if he says that my wife has given me her consent, she said that
no,
even
no,
then
no,
also we will not share now.
no. You can't say that.
Okay,
And
ma'am.
role play
Thank
are
you.
primarily don't lie to you. They are not told to, lie to you about these kind of things, right? It can just come to you and demand that, you get this, this, that. But without partner's consent, okay, written or she is present and she tells you, tell him, then that's a different thing. Both are brought in front of you and you're sitting there and then you are to discuss reports, you still will ask permission. Is it okay to discuss your reports in the presence of both, and then go ahead with discussion? That's how it usually goes. So fertility consultations practically are done by couple. It's not done by one individual. But in exam, you're going to have only one role player, and you will have this kind of an issue. If they ask you, You have to say, I don't know. If they tell you that I know the report, that is to make your life easier. Okay? So, understood? So,
Yes, ma'am.
yeah. All right. Okay, guys. Got to go for something urgent. So I think any other questions you can put on the group. All right. Hope this helps. Thank you.
Thank you, ma'am. Thank you.